you very much. I'm really honored and pleased to be here and participate in this prestigious meeting and participate in this joint meeting with Bhaskar and JS, which is at and the Indian colleagues. I think this is a great initiative, and I hope this will be maintained as a tradition in the future edition of this Congress. So I was asked to talk about left atrial appendage closure, the need, and the current situation in Africa. I have no disclosures. By the way, there is no much happening in terms of current situation in Africa because there are 4 countries where this procedure have been or was performed as usual: South Africa, Egypt, Tunisia, and 2 or 3 cases in Morocco. So, and nothing else. And that's why we are in the stage we're trying to promote this technique, because indeed it's an important procedure for all the population, by the way, and particularly in the African population, where actually access to anticoagulants for atrial fibrillation, non-valvular atrial fibrillation. We don't talk about valvular atrial fibrillation, which is another topic, but with non-valvular atrial fibrillation, it's a difficult context to access to medication and to control ANR later on. So why do we have to close left atrial appendage? Because, you know, every one of us knows that very, very well. I mean, atrial fibrillation is going up, and it is very rare to see patients after the age of 50 who is not an atrial fibrillation. 1 in 4 middle-aged adults in Europe and the United States will develop atrial fibrillation by 2030, and it's going up, actually, because the aging of the population is going up. So as long as the patient will get old, the likelihood to be in atrial fibrillation will go up. And in fact, the percentage of ischemic stroke attributable to atrial fibrillation will go up with age. So if you consider patients between 50 and 59, it's only 10%. But if you consider patients with above 80 of years of age, this will go up to 35%. The other really important element of information is that in 90% of cases, the thrombus in non-valvular atrial fibrillation will originate actually from the appendage itself. So that structure is the source of the problem. Now, warfarin, of course, it has been very useful over the years, and you remember these trials that have shown the benefit of warfarin for stroke prevention, atrial fibrillation compared to placebo. But we all know that there is a problem with warfarin use in real life, and in all these studies and registries, approximately 41 to 65% of eligible patients with atrial fibrillation, many of whom are considered warfarin unsuitable. So there is a problem in the use of warfarin, and there is a problem, by the way, of using that medication even if eligible patients. This is a registry that we have conducted a few years ago with the help of Philippe Gabriel-Stack from Bichat in France and other colleagues. It has included 10,000 patients from 4 continents, and we have explored actually the use of oral anticoagulants, antiplatelet therapy, non-valvular atrial fibrillation, and what we see in hatched here, in hatched bars, are the patients who are receiving inappropriate treatment. And you can see overall the study, the 10,000 patients, approximately 40 to 50% of patients were not receiving anticoagulants appropriately. Now, how about Africa and the Middle East? We have also conducted the same analysis in that population, and it is a little bit less, maybe 35%, but 35 to 40% of patients, they were not taking anticoagulant therapy as indicated. So there is an issue with that. Now, patients who are taking warfarin, in general, they have the tendency of adhering less over time. And you can see that whatever is the age, adherence will go down over the years. Is it better using NOACs? Maybe a little bit better. This is the red curve. And you can see also the trend is going down. So chronic anticoagulants have a problem of adherence to treatment and is going down over the years. Now, in practice, we are stuck with some challenging situation like this one. This is the case of 73 years old male, diabetic hypertensive, AF since 4 months, anticoagulant by vitamin K antagonist, 2 episodes of severe epistaxis requiring transfusion despite optimal INR, what would you do? Second case, 75-year-old female, hypertensive, dyslipidemia, permanent AF since 2012, treated by vitamin K antagonist, hemorrhagic stroke 2 years ago, and then we have to stop vitamin K antagonist. But after stopping, 7 months later, she developed ischemic stroke. So what would you do? So it's also a challenging clinical situation. Now, our surgeon, cardiac surgeons, they have thought about this many years ago, because they are used actually to close, to exclude completely the appendage in patients who are operated particularly for mitral valve disease and mitral valve replacement. Why? Because they do know that these patients, they would stop anticoagulants. So it's an old procedure actually performed surgically. Now, for the last, I would say, 15 years, there have been a development of a big number of devices that will be closing the appendage percutaneously. You can see this list, but the list is even longer. Perhaps the 2 most used devices are the Watchman device. I will show you how we use it, because this is the device that we're using in our center, and the amulet, the on-Platzer cardiac plug device. So this is what it looks like. This is the amulet, the Watchman. The Lariat is an interesting device too, and the wave crest. The Watchman, it's a nitinol, several sizes. It's CE mark already. The FDA was approved in 2015. For those who are using this, you have certainly noticed there is a very important technical refinement that was done on the latest device, which is called the Watchman Flex, as compared to this generation, which is called the 2.5 generation. You see that it's smaller, it is less, the length is less, and then it's much easier in its use. This is the way it is. I mean, you make the ball, and then you can manipulate the device and try to place it where it should be. This is the instruction for use sheet. It's quite interesting. This is for the Watchman, the previous version. This is for the Watchman Flex. What is really interesting is it for a large range of sizes of the appendage, you can use one device. So it's more comfortable as opposed to the previous version, where the 21 millimeter device, for example, would fit in 17 to 19 only. So you're more comfortable with the new device. How prepare the patient? Of course, you have to stop coagulation. ANR should be normal. You can make the bridging with heparin. Start with TEE. TEE is absolutely key for the preparation and for the performance of this procedure. It is done under TEE guidance, mild sedation or no sedation. One important piece of information is to have an idea about the anatomy, mainly whether if the patient has a single or more than one lobe, then it makes, of course, the procedure more complex. One important information too is to look at the appendage, whether there is a clot or not. Clot, theoretically, is a contraindication for the procedure. It's no longer contraindication. You know, as usual in medicine, we make progress. So for very experienced operators, if it is a small clot that is organized at the tip of the appendage, you can go ahead and do it, maybe with the amulet more than with the Watchman, so you don't take the risk to go inside the appendage completely and mobilize it. But theoretically, it should be a contraindication. Again, single multiple lobes, important piece of information, and the measurement. This is absolutely key. You need to have an accurate measurement of the appendage and where we should land your device. Otherwise, I mean, you can perforate if it is not in the right place, and you can, of course, embolize if it is up of the appendage. Where to puncture the septum? The septal puncture should not be done by fluoroscopy. It doesn't work. It has to be done by TEE, inferior and posterior puncture. Then after the puncture, you go ahead with heparin. You make the exchange of the sheath, and you place a dedicated sheath that goes to the appendage, and then you make an appendogram. Once again, you make other measurement, because measurement is absolutely key for the appropriate selection of the device to be placed. It's important to mention that usually it is better to slightly oversize, as it is indicated here in the instruction for use. So if it is 20, if it is borderline 18 millimeter, for example, ostium of the diameter of the appendage, and you're hesitating between the 20 or 24, it's rather better to select the 24 millimeter device. Before release, you have to make the position, and you have to look for the residual compression, meaning that you see how much your device is compressed after deployment, and that compression should be around 20 to 30%. Then you make what is called the tuck test. For those colleagues who have been using, for example, closing the ASD, it's the same procedure. So you have to try to retrieve the device and see if it goes back, and this is before releasing. Let me see if there is, should be work. Okay, let's see. It's not working for some reason, but it's you can make the tech test by fluoro, but you can do it by TE. So you, before releasing it, you try to retrieve it, and then you you release it, and you see that the device will go back to the appendage, and you're sure about the stability. And then you perform a TEE looking for residual flow. If there is a residual flow, meaning that you're not effective in preventing thrombus in the future. So it's important to make sure that you have no residual flow. Then you release the device. You unscrew by turning the release knob counterclockwise, and also you hope that it stays there. And of course, you make cine. This is exactly what you don't want to see. Is to see this device embolize. This is the nightmare for the interventional cardiologist for doing this procedure. Now, after release, final angiogram. This is the first patient that I have presented to you. This is the way it is. So you go very, very slowly. This is 2.5 device. And then you make the tuck test. Tuck test. So before releasing the device, you try to pull it back, and you see that it goes back to the appendage, meaning that it's quite stable. This is what how it looks like after release. Post-procedure care, you might consider protamine, but it's not necessary. Aspirin for 6 months, Plavix for 3 months, endocarditis prophylaxis for 6 months. There is no science behind these timelines. So it's variable from one team to another. This is what we do in our center, and we perform TEE after 4 weeks and 6 months, looking for what we call DRT, device-related thrombus. This is something that might occur. It occurs between 5 to 20% of cases, and in that case, you have to resume once again anticoagulant therapy for a few weeks in order to see that DRT disappearing. So, what are the results so far? There is quite good number of tries. Mainly, the WatchMind device was the one that is that was used for these tries. Protect AF, Prevail are probably the most famous tries. Protect AF efficacy at 4 years. It has been conducted in the early 2012 and later. This is the publication 2014 showing the 4 years results of Protect AF comparing WatchMind versus warfarin in patients who can take warfarin, and you can see that the primary endpoints, stroke, systemic embolization, and cardiovascular death, were better in the WatchMind device. In terms of safety, there was no problems in terms of safety between the two groups. And now, in terms of mortality, and this is really a striking result that hasn't been shown in other trials, but in the Protect AF, it has been shown very clearly. This is the cardiovascular mortality, better with the WatchMind device. and this is the all-cause mortality, again, significantly better with the Watchman device. The Prevail that was performed 2 years later did not show that, but it has shown a non-inferiority of the use of the Watchman device compared to warfarin. But what Prevail has shown is that the percent of complications had dramatically decreased, meaning that actually if you do more and over time technology has been refined and the complications has substantially diminished over time. So today, LAA closure is even safer and more successful than in the early trials. These are the trials and registries using the left atrial appendage closure. In the early years, there was only 50% new operators. In the latest, there's 70% new operators. So even the learning curve, it's a little bit steep, but not that steep. So even with new operator, you can achieve good result with a success rate approaching 98% or even more. Complications, again, with time, goes very low. Pinnacle Flex registry published very recently, 0.5% of complications rate. This is remarkable. Now, how does LAA closure compare to NOACs? We have been waiting for this trial, for the Prague 17 trial that have compared NOACs versus LAA closure, and this is the result. It has been published quite recently. LAA closure was non-inferior to NOACs after only 21 months of follow-up. So we have a substantial amount of science confirming the safety and efficacy of this device, but guidelines still don't want to move. It's only 2B. This is the European guidelines. This is the American guidelines. Just 2B, and we're waiting maybe for more trials, perhaps larger number of patients included, in order to change that that level of recommendation of the guidelines. LAA closure in whom? Simply non-rheumatic AF with the chest fast more or equal to 2 with the challenges with the oral anticoagulants. Probably this is the simplest indication. Of course, the ideal patient would be the patient who cannot take long-term anticoagulants, who has issues with compliance, don't want to take long-term anticoagulants, so it's an issue of lifestyle, and patients who have stroke on anticoagulants. Are there complications? Of course, I have shown you one of these, which is device embolization, but you might have thrombus on the device, the DRT, air embolism, thromboembolism, pericardial effusion. So this is the complications that I have shown. Is there a solution? Yes, there is a solution. You have to snare it. You have to be very patient and snare that embolized device, and you can take it out of the body. One last picture. This technology is being very much developed, and the latest technology now, it's what is called the applicator. The applicator is LAA closure without implant. It's independent from shape and size of the LAA. It achieves complete sealing based on the concept of invaginations. Unfortunately, I don't have the video here, but it's a very nice procedure. You don't put a device, you don't leave a device behind, but you just close it percutaneously. So in conclusion, LAA occlusion is an excellent alternative and life-saving procedure for many AF patients, particularly those with contraindication to oral anticoagulants. And LAA closure with current devices is well established in clinical practice. Newer devices are in the pipeline, and important features of new devices are independent from LAA size and shape, leaving less behind. Now, adequately powered control trials, that's what we need. That's what we need, are urgently needed to inform the best use of these devices and change the guidelines. Thank you very much.